Good morning. I am Madhavram Balakrishnan. I am working in the Department of Essential Medicine and Health Products in the WHO headquarters in Geneva. It gives me great pleasure to discuss with you the causality assessment for adverse events following immunization in the next few slides. Let me introduce this red dot to you. This is the laser pointer, and I will be highlighting important aspects of this presentation using the laser pointer. In 2009, the WHO and CIOMS defined an adverse event after immunization as any untoward medical occurrence which follows immunization and which does not necessarily have a causal relationship with the usage of the vaccine. One of the important parts of the definition is what follows. The adverse event might be any unfavorable or unintended sign, abnormal laboratory finding, symptom, or disease. Therefore, if we take the example of this healthy child and after immunization, it could develop a symptom like cough or a sign like icterus, or a lab finding like thrombocytopenia, or a disease like purpura, and we may have to think about an adverse event after immunization. The objectives of this presentation are to explain what is causality assessment, to list the 4 steps in the revised causality assessment methodology, and to explain the practical aspects of causality assessment. Before we begin, let me introduce this worksheet for AEFI Causality Assessment. Please make sure that this worksheet is in front of you right now. If it is not in front of you right now, please collect the worksheet from the person who is in charge of this session today. I shall wait for a few seconds. Okay, I hope you have got it in front of you. So if you see the worksheet, it has got 2 pages, page 1 and page 2. If you just look at page 1, it has got 2 steps. Step 1, which is the eligibility, and step 2, which is the event checklist. If you just look at page 2, it has got 2 steps as well. Step 3, which is the algorithm, and step 4, which is the classification. Now, in this worksheet, all the steps are very important. And it is very important also to see that we go through each step in a systematic manner. But for convenience right now, I'm going to focus on 2 steps. That is step 2 and step 3. Now let's look at step 2, the event checklist. The event checklist, or the step 2, has got 4 sections. The first section here is there strong evidence for other causes? The second section here is there known causal association with vaccine or vaccination? The third section here is there any strong evidence against a causal association? And the fourth section here is other qualifying factors for classification. Now you will notice that there is one question for section 1. There are actually 9 questions here for section 2. There is 1 question here for section 3, and there are 8 questions here for section 4. It is mandatory that you have to answer all the questions with one of the 4 options. Either you can say a yes, a no, or an unknown, or a not applicable. So this is very, very important criteria which has to be fulfilled before causality assessment can be done. I would also like to caution you that if whenever you get an answer of yes, if you get a S answer, it is also essential that you complete the statement why you have got a S answer in the remarks column. So this is the basis with which you can do a causality assessment very systematically. Now, let us see the linkage between step 2 and step 3. If you want to see the linkage between step 2 and step 3, it is actually quite simple. You will see that the first section of step 2 is actually linked to the first box of the algorithm. Similarly, the second section of step 2 is linked to the second box of the algorithm, and the third section of step 2, that is the checklist, is linked to the third box of the algorithm, and the last section, that is section 4, other qualifying factors, are related to the fourth box of the algorithm. So this concept of linkage between the event checklist and the algorithm is the key to understand causality assessment procedure, which we will be discussing in the next few slides. Okay, let us understand this concept of causality and causality assessment. Causality is the relationship between two events, the cause and the effect, where the second event is a consequence of the first. And causality assessment is determining if such a relationship exists, and if so, to what extent. Causes can be of two types. One is the direct cause. The absence of this particular cause means that the effect will not occur. The typical example in the vaccine world is the BCG vaccine and the occurrence of a scar. In this case, you can always say that the BCG vaccine caused the scar. But sometimes it is not so straightforward. Let us take the example of a child with an unknown congenital heart disease. Now this child with this unknown congenital heart disease, let us say, has received the DTP vaccine, the first dose. Now what happens? On the subsequent to the DTP vaccine, the child maybe 2 days later develops dyspnea, breathlessness, and after another 2 days the child dies. So when the postmortem was done, they have identified a congenital heart disease. At this particular point, we cannot attribute the DTP vaccine to the death, because there is also another factor, that is the congenital heart disease. And the congenital heart disease definitely is what led to the death of the child rather than the fact of administering the vaccine itself. Now, why do we want to do causality assessment for AEFI? We want to do causality assessment for AEFI to automatically avoid concluding that the event happened after vaccination and therefore it happened because of vaccination. The best way to do this is actually a randomized trial where you have a group of people where you divide them into a group of vaccinated group, into another group which is the unvaccinated group, and then you follow them up over a period of time. Now, if the occurrence of adverse events in the vaccinated group is greater than the number of events which take place in the unvaccinated group, then we can say that there is a causal relationship between administering the vaccine and the occurrence of adverse events. But unfortunately, many of the times it is not possible in the field situation to do this. Why? Because many of the countries and many places, the vaccination coverage may be very high and it is very difficult to find an unvaccinated group to compare. Sometimes it may not actually be, even if there is unvaccinated groups in some places, it may not be possible to do this matching between the vaccinated and the unvaccinated groups. Therefore, that is the reason why we have to do causality assessment for individual cases after adverse events following immunization. The WHO and CIOMS have divided AEFI into 5 categories based on their causes. The first one is a vaccine product related reaction. Now, a vaccine product related reaction is a AEFI which is caused or precipitated because of the inherent property of the vaccine product. This means even if the best vaccine is administered, it will by itself produce some inherent AEFIs. One of the example is this thrombocytopenia which can occur after the measles vaccine. Now, all of us know that thrombocytopenia after measles vaccine can occur at the rate of 1 in 30,000 doses of measles vaccine administered. The second one is a vaccine quality defect related AEFI. Now, in simple terms, this means that there is some problem with the manufacturing process of the vaccine, which has resulted in the AEFI. One of the typical examples is the famous Qatar incident which occurred in 1955 when IPV was not inactivated sufficiently and it resulted in polio cases occurring in the general population. The third one is the immunization error related reaction. In simple terms, this is actually what was formerly called program error. This is the immunization error related reaction occurs because of inappropriate vaccine handling, prescribing or administration, and it is definitely preventable. One of the typical examples is actually the transmission of infection because of contamination of a multi-dose vial. We get the condition called the toxic shock syndrome. Now, the fourth one is actually the immunization anxiety related reaction, and this is actually occurring as a result of anxiety about immunization. Sometimes we know that especially teenage children can develop vasovagal syncopes following vaccination. We also have the last set, that is the coincidental event, which occurs by something other than the vaccine product or immunization error or immunization anxiety. For example, if a fever following immunization, and then when we do a test, we find that we are able to isolate a malarial parasite from the blood. Now, this is a very typical example. Now, before we go into the formal causality assessment, first of all, we need to choose the cases. Now, which are the cases we are supposed to select for formal causality assessment? Do we take all the AEFI cases which is reported, or do we have to select certain cases? It is important for us to identify and select only specific cases for causality assessment, and it is not necessary to do causality assessment for all cases which is reported. So, what do we do it for? We do it for serious AEFI cases, which includes death, hospitalization, significant disability, AEFI which is life-threatening, or congenital anomaly, or a birth defect. We can also do causality assessment for clusters and events above the expected rate and severity, and when we suspect signals, and also other AEFI as decided by a national committee or a subnational committee. If an immunization error is suspected, if there are significant events of unexplained cause, particularly within 30 days of vaccination, and events causing significant parental or community concern, conditions like HHE or febrile seizures, they have to definitely go in for causality assessment formally. Okay, So before we actually start off with the actual assessment, there are certain criteria that has to be satisfied. The first and foremost criteria is that the AEFI case investigation should have been completed, and all details of the case should be available at the time of assessment. This includes not only the event but also the circumstances which led on to the event, plus the events which took place subsequent to the event, like what happened to the case, where was the case admitted, whether the case was treated, what kind of treatment, what was the response to treatment, what were the lab results, lab findings, autopsy findings, everything. So all details must be available at the time of assessment. Then the most crucial point is that there must be a valid diagnosis. Now, what is the meaning of this word valid diagnosis? Now, when we talk about a valid diagnosis, it refers to the extent to which the unfavorable or unintended sign, abnormal lab finding, symptom or disease is defined. It is not possible for us to do a causality assessment if you say a particular vaccine produced death. It is not possible to evaluate or do a causality assessment because a vaccine just cannot produce death. There must be a reason why the child or that patient died. Like, for example, we can always say the patient died of anaphylaxis, the patient died of shock, the patient died of pneumothorax, the patient died of meningitis. But we cannot say that the patient died of vaccination. So this is important. So you should have a very clear idea on what we are talking about at the time of causality assessment, because we are trying to link the valid diagnosis to the vaccine and not the outcome like the death to the vaccine. Now let's come back to the 4 steps for causality assessment and see why exactly we need to have these 4 steps. The step 1, eligibility, is required to determine that the AEFI case satisfies a minimum criteria for causality assessment. The step 2, that is the checklist, is required to systematically review the available information. And step 3, the algorithm, is required to obtain a trend on the causality with the checklist information. And step 4 is required to categorize the association of the AEFI to the vaccine or vaccination. Now, steps 1, 2 and 3 are ones which will automatically come through a very systematic process, and you can even use a computer to reach up to that particular step 3. But when you look at step 4, this is where the human element comes into the picture, and a decision on causality has to be made at step 4 based on the findings and observations on step 1, 2 and 3. Now let's look at the steps one by one. The first step is eligibility. First, we need to have the AEFI case in front of us. And as I told you earlier, the investigation should have been completed. Now, it's a good idea to retain the case details in a retrievable database. The reason is you may decide to go back to other cases and find out if there are any similarities. The next crucial thing is to identify the vaccine which is responsible. Now, you may find that a child is administered multiple vaccines at the same time. But when you do causality assessment, it is critical that you should identify one vaccine which is administered before the event, which is suspected, and do the causality for that particular vaccine. So, if you find, for instance, that DTP, OPV and hepatitis B were administered at the same time, and if you are suspecting the DTP vaccine to have caused the adverse event, then you should use only DTP. Now what about the remaining vaccines? You should do this, repeat the same process for all vaccines separately. Now we have already discussed the valid diagnosis, so I'm not going into that particular part, but as I told you, this is a very key part of this entire process. And we need to have a case definition for the valid diagnosis. So for a case definition, we have a standard set of case definitions which are available online. We have the case definitions of the Brighton collaboration, and in case those case definitions are not applicable or not available for some reason or the other, you can use standard literature case definitions, or sometimes national definitions or other approved definitions can always be used. Now we come to the main part. I want you to look at the worksheet in front of you and look into this box which is provided. This red box is the key. Now when you look at this red box, you have to make a statement, and this statement is the hypothesis. So you have to make a statement. Has this particular vaccine here, where you write the vaccine name, caused the particular event? So the examples of these causality questions are actually given here. Like you can say, has this particular vaccine caused hepatomegaly, which is a sign, or has another vaccine caused thrombocytopenia, which is a laboratory finding, or a vaccine has caused itching and redness, which is an example of a symptom, or a vaccine has caused meningitis, which is an example of a disease. So this is crucial before we start off with going for the causality assessment. Now that we have completed step 1, let us proceed to step 2, the checklist. As I mentioned earlier, there are 4 sections in the checklist: 1, 2, 3, and 4. Now each of these sections have got questions. Section 1 has 1 question. Section 2 has actually 3 subsections, and it has got 9 questions. Section 3 has 1 question. Section 4 has 8 questions. To each of these questions, it is necessary to give an answer as to yes, no, unknown, or not applicable. And you will be getting a response for all the questions which are there. So if you get a yes response to any of those questions, it is essential that you should state why you are saying yes in the remarks box adjacent to that particular question. Now, an interesting thing here is, like if you get a yes response to any of the questions in section 2, it is also necessary to add one more extra question, and that is this question on time. Was the event within the time window of increased risk? And answer that as well. Now that we have completed step 2, let's go down to step 3, the algorithm. The algorithm has got 4 boxes, and these 4 boxes correspond to the 4 sections in the checklist. There is also a box corresponding to the section on time in the checklist. So the final framework for the algorithm will look like this. Now that this framework is ready in front of us, we just have to get back to the checklist and look for the yes answers. If you look at the section 1 and if you see the question there, if you get a yes answer, you would conclude that it is inconsistent causal association to immunization, and you would put a tick here. If you go to the section 2 and then if you see that there are yes answers there to the question, is there a known causal association with the vaccine or vaccination, and if there are any yes answers there, you would go back and check for the time factor. Was the event within the time window of increased risk? And if the answer to that was yes, you would conclude that it is consistent causal association to immunization, and you would put a tick here. Now you come to the third part, that is there strong evidence for causal association, and you look for evidence, and if the answer to that was yes, then you would conclude that it is an inconsistent causal association to immunization, and you would put a tick here. So we have finished the primary part of the algorithm. We have reached the last part of the algorithm where we review other qualifying factors. And at that point in time, we would be able to ask ourselves, is this event classifiable? Now, if the answer to any of those questions were yes in this section, in that case, we have to take a decision whether the yes answer has to go into the section on consistent causal association to immunization, or if it was indeterminate causal association to immunization, or it was an inconsistent causal association to immunization. If the answers to that was also no, in that case we would say that the case was not classifiable. Now that we have finished step 3, the algorithm, let us go on to the last step, classification. Before we go into the details of the classification, the first question which we need to ask ourselves based on the available evidence is, do we have sufficient information available, or do we not have sufficient information available? If we do not have sufficient information available, straight away we would say the case is unclassifiable. We would also specify exactly what is the other additional information required for classification, and we would not waste time proceeding further. Now, if we have adequate information which is available, then we go back to the algorithm and look for the trends. From the algorithm, we will be able to determine if it is consistent causal association to immunization, inconsistent causal association to immunization, or indeterminate. Now, this is where the human element comes into the picture in causality assessment. If it is a consistent causal association to immunization, it could be a vaccine product related reaction, or a vaccine quality defect related reaction, or an immunization error related reaction, or an immunization anxiety related reaction. If it is an inconsistent causal association to immunization, then we would be calling it a coincidental event, where it could be because of an underlying or an emerging condition, or it could be caused by exposure to something other than the vaccine. Now, in between these two categories of consistent and inconsistent, we are having this category which is indeterminate. Now, indeterminate category is of two types. One, it could be where the temporal relationship is consistent, but there is insufficient definitive evidence for vaccine causing the event. That is, it may be probably a new vaccine-linked event. The second option under indeterminate is that qualifying factors result in conflicting trends of consistency and inconsistency with causal association to immunization. Now, I will explain particularly the indeterminate parts in the next slide with examples, when it will become much more clearer. Now let's look at some of the examples. The examples for consistent causal association to immunization is pretty straightforward. I already explained it to you. so I'm not going into too much of details. The example for a vaccine product related reaction is a thrombocytopenia after MMR vaccination. The example for a vaccine quality defect related AEFI is a paralytic polio caused by the failure of the manufacturer to inactivate IPV completely. Or if it is an immunization error related AEFI, it could be a transmission of infection by a contaminated multi-dose vial. Or if it is an immunization anxiety related reaction, it could be a fainting attack in an adolescent following vaccination, or a vasovagal syncope as we call it. Now, the inconsistent causal association to immunization, there are two characteristics. One was something from inside coming out, that is a coincidental event where a child dies after DPT vaccine and autopsy shows a congenital heart disease. Or it could be something from outside coming in, like a fever which occurs after vaccination, and when you examine the blood, we find that malarial parasite is positive. So these two are pretty straightforward. Now let us look at the indeterminate category and spend some time on that. Now the first category for indeterminate was that there was temporal relationship with vaccination, but there is insufficient definitive evidence that the vaccine caused the event. It means by time the vaccine is related to the adverse event. That is, the adverse event occurred within a reasonably good time after the vaccine has been administered to call it that it is related to vaccine. But unfortunately, this particular event has not been reported earlier, or it has been reported earlier but it has not been proved. So in other words, there is insufficient definitive evidence that the vaccine caused the event. An example would be irritable bowel syndrome after TT vaccine, which is hypothetical and not proved so far. Now the second one is that there is conflicting trends of consistency and inconsistency between the vaccine and the event. Now a typical example would be a child living in a dengue endemic area has developed, after measles vaccine, has developed thrombocytopenia. Now we do not know whether this thrombocytopenia in the child has occurred after the MMR vaccine in a dengue endemic area, or whether the dengue itself was responsible for the thrombocytopenia. If the MMR vaccine was responsible for the thrombocytopenia, we would have classified it under A1. But if the dengue was endemic, since dengue was endemic in that area, the thrombocytopenia would have been classified as a coincidental event here. So this actually brings about a conflict whether we can classify it into a consistent or we can classify it as inconsistent, and therefore we conclude that it is indeterminate under B2. One of the key considerations for causality assessment is the valid diagnosis. Without having a clear valid diagnosis, we just cannot proceed with causality assessment. And so also, without using the valid diagnosis to create your hypothesis, we just cannot proceed with causality assessment. Another thing which has to be kept in mind is the fact that the first conclusion may not be final. As more information becomes available, the causality can change even if the case has got adequate information. Because as medicine evolves, You may look back at some of your old cases and then look at the evidence which is available in the literature recently. Look back at your old cases and say that the causality was actually different and it may actually be changed. Now the question comes up, what happens with multiple vaccines with multiple AEFI and what to do for AEFI clusters? Now, if there are multiple vaccines which are provided to the same patient resulting in an event or events, each vaccine should be assessed separately. Similarly, if there are multiple AEFI in the same patient, each event should be listed separately and separate eligibility question in step 1 should be asked and the case should be independently evaluated. In case of AEFI clusters, each patient in the cluster should be separately evaluated. So we come to this particular question as to who should assess causality for adverse events after immunization. Can it be done by the peripheral health worker who first sees the AEFI case? The answer is ideally no. It should be done by a group of specialists who constitute an official committee or a team that should be independent and totally free of real or perceived government or industry conflicts of interest. They should have a broad range of expertise as shown in the slide, preferably. And as far as possible, we should try to get expertise from as many sources as possible. It may not be always possible to get these experts, but it should be tried as far as possible. They should have a clear terms of reference. It is possible to make use of an existing drug causality assessment team, but then it is necessary to keep in mind that it has to be modified and adapted to fit vaccines. Now we need to look at what can go wrong in causality assessment. A lot of things can go wrong. Causality assessment may not be done and not done sometimes systematically, not done by trained personnel, and most crucially, not done on time. Sometimes the information on the reports which have been presented to this committee is so limited that causality assessment cannot be done. Now, the quality of the causality assessment is dependent on the expertise, the independence of the review committee which is responsible for the causality assessment. And this can have a great impact on the outcome of the assessment as well. Many of the time data is available to all of us, but unfortunately it may not be analyzed, and this may result in the delay of recognition of clusters and program errors. Many of the time, in fact, after doing a lot of work, we find that there may be lack of communication of findings. They may not be addressing all target audiences, and the way in which the findings are presented may lack, tact, diplomacy, and cultural sensitivity. What are the advantages of the revised causality assessment scheme? The revised scheme ensures that all the cases are classified according to the CIOMS WHO guidelines. It incorporates the major criteria affecting causality. It's got a very flexible approach so that the causality itself can change as more information becomes available. But then we should also remember it has got a big problem that if we do not have sufficient information, you cannot also classify and determine causality. It minimizes errors. It is simple to use. No technology is involved. You can just use a piece of paper and you can arrive at your conclusion. It can be adapted to computer logic if necessary, particularly the steps 1, 2 and 3. And last but not the least, it's a very convenient tool to teach and to learn. I wish to thank you very much for your time, patience and attention. I am happy to answer any of the questions you might have. Thank you very much.